Welcome to the deep dive. This is where we really get into fascinating source material, articles, research, uh, expert notes, you name it, and just immerse ourselves looking for that core knowledge, those key insights.
Exactly.
Today, we're diving deep into excerpts from a physiology text, our mission, to get a really thorough understanding of circulatory shock.
A critical topic.
Yeah, and we want to approach this like the professionals do,
Yeah.
covering everything the source lays out, aiming for that deep expert-level grasp.
Sounds like a plan. This text gives us a solid physiological base for understanding, why shock happens, how it progresses, and what the body and medicine can actually do about it. We'll unpack all those core concepts from the source.
Okay, great. Let's start right at the beginning then. According to this text, what is circulatory shock fundamentally? What's the core problem?
At its absolute heart, circulatory shock boils down to inadequate blood flow. It's a generalized, body-wide issue where tissues just aren't getting enough oxygen and nutrients. And just as importantly, the waste products aren't being carried away effectively either. Think of it as a crisis at the cellular level, all because the transport system, the circulation, is failing.
So it's not just about, say, a low blood pressure number. It's deeper than that. It's about what's happening or not happening in the tissues themselves.
Precisely. And here's something really crucial the source points out. Once shock gets severe, the circulatory system itself starts to break down. The heart muscle weakens, blood vessels lose their tone. The control systems get impaired.
Wow.
And that's huge because it means severe shock tends to feed on itself. It becomes progressively worse. It's a really dangerous cycle.
A vicious cycle.
Yeah.
We definitely need to unpack that more later. So the source says shock usually starts with inadequate cardiac output, or CO. Let's quickly define CO.
Right. CO is cardiac output, basically, how much blood the heart pumps out each minute. The text highlights two main reasons CO can drop off dramatically. First, problems with the heart itself. Anything that stops it from pumping effectively.
Like a mechanical issue with the pump.
Exactly that. The source gives examples like myocardial infarction, a heart attack which damages the muscle, or toxic conditions affecting the heart, severe issues with heart valves, or arrhythmias, those irregular heartbeats.
And if the heart failing is the direct cause of shock, there's a specific term for that.
Yes, that's cardiogenic shock. And it's pretty sobering. The source notes the mortality rate can be incredibly high, like up to 70%.
70%. That really drives home how vital that pump is.
Yeah.
Okay, so a failing heart pump is one major cause of low CO. What's the second main category?
It's anything that decreases venous return. Basically, the blood coming back to the heart through the veins. You have to remember the heart can only pump out the blood that it receives.
Right, can't pump what isn't there.
Exactly. So if the volume of blood returning or the pressure driving it back is too low, cardiac output has to fall.
And what makes venous return drop? What are the common reasons?
Well, the most common cause, according to the source, is simply diminished blood volume. Think hemorrhage, losing blood, or severe dehydration.
Okay, less volume in the system.
Right. But it can also happen if there's a decrease in vascular tone, especially in the veins. Veins are like reservoirs. They hold a lot of blood. If they suddenly dilate, blood just pools there instead of returning to the heart.
So the pipes get too wide.
Sort of, yeah. Or you could have a physical obstruction somewhere in the return path, literally blocking the blood flow back to the heart.
Got it. So pump failure, not enough volume returning, or a blockage. But the source also mentions this less common situation. Shock without low cardiac output. How does that work?
Yeah, this is interesting. The SFO might actually be normal or even high, but it's still shock because the tissues aren't getting what they need. The source gives two main ways this can happen. One is just an excessively high metabolic rate throughout the body.
So the body's demands are just overwhelming.
Exactly. The tissues are burning through oxygen and nutrients so fast that even a normal cardiac output can't keep up. Supply just can't meet this hyper demand.
Like trying to fill a swimming pool with a garden hose.
Good analogy. The second scenario is abnormal tissue perfusion patterns. The total blood flow might be fine, but it's not going where it needs to go effectively.
How so?
It might be getting shunted, bypassing the crucial capillary beds where oxygen and nutrients are actually exchanged. So the flow exists, but it's not useful flow for nourishing the tissues.
Ah, okay. So the bottom line is always inadequate tissue perfusion, whether CO is low, normal, or even high. The end result for the cells is the same.
Exactly right. The mechanism differs, but the endpoint compromised tissues is the constant.
You mentioned earlier, and the source really emphasizes this, that arterial pressure can be misleading. Why isn't blood pressure a reliable standalone sign of shock?
This is such a key point and often misunderstood. The text explains that the body has these really powerful nervous reflexes, particularly the sympathetic nervous system. In early shock, these can kick in strongly and actually keep arterial pressure pretty close to normal, even though blood flow to the tissues is already dangerously low.
So the monitor might look okay, but the patient is actually in deep trouble.
That's the danger. And conversely, the source also points out that someone's pressure could drop significantly, maybe even by half. But if their tissue blood flow is still adequate for their needs at that moment, they aren't technically in shock.
So pressure is a piece of the puzzle, but not the whole picture.
Exactly. It's the tissue perfusion that truly defines shock. That said, in most common types, like shock from bleeding, the arterial pressure does eventually fall along with cardiac output. It just might not fall as much or as quickly initially because of those reflexes compensating.
Okay, let's circle back to that vicious cycle concept. The source really paints tissue deterioration as the grim outcome. How does shock become self-perpetuating once it hits a certain severity?
It's a truly devastating positive feedback loop. When blood flow gets really inadequate, tissues all over the body start suffering damage, lack of oxygen, lack of nutrients, and critically, this damage hits the circulatory system itself.
So the system that's failing starts damaging itself further.
Precisely. The heart muscle gets weaker, so it pumps less blood. The blood vessels lose their ability to constrict properly, they get leaky. This further reduces blood flow, which causes more tissue damage, which further impairs circulation.
And it just spirals downwards.
It absolutely does. Progressively worsening shock leads to less adequate perfusion, which leads to more severe shock, and eventually, if uninterrupted, it leads to death. The source really stresses that a major goal of treatment is trying to break that cycle, especially in the later stages.
Breaking the cycle is key.
Yeah.
Okay, to help us track this progression, the source divides shock into 3 main stages based on severity.
Yeah, understanding these stages is fundamental. First is the non-progressive stage, sometimes called the compensated stage. Here, the shock isn't too severe, and the body's own amazing compensatory mechanisms are actually strong enough to overcome the problem and bring about full recovery, even without outside help.
The body wins the fight on its own.
Essentially, yes. The negative feedback systems prevail.
But what if the shock is worse? Too much for those natural defenses?
Then you enter the progressive stage. Now, without therapy, the shock just gets steadily worse. Those vicious cycles, those positive feedback loops we talked about, start to dominate. The body's own mechanisms are overwhelmed, and it heads towards death.
And the final stage?
That's the irreversible stage. At this point, the damage is just too extensive. The shock has progressed so far that even if you give the best possible treatments, they won't be enough to save the person's life. Death is inevitable, even if circulation can be temporarily bumped up.
Irreversible. That word really hits home, the severity of it.
Yeah.
Okay. The source uses hypovolemic shock, especially from hemorrhage, bleeding, as a primary example to illustrate these stages and principles. Let's dig into that. What exactly is hypovolemic shock?
Hypovolemia just means low blood volume.
Yeah.
Hypo meaning low, volemia meaning volume. And hemorrhage or bleeding is the most common way you lose blood volume quickly. So when you bleed, the total volume circulating drops. This lowers the overall pressure in the system, which directly reduces venous return, the blood getting back to the heart. Less blood returning means less blood pumped out, lower cardiac output. If that drop is big enough, you get hypovolemic shock.
The source mentions a figure concept, like figure 24:1, showing how the amount of blood loss affects CO and pressure. What's that relationship look like?
Right. So losing a little bit of blood, maybe up to 10% of your total volume, the body compensates so well you barely notice an effect on CO or pressure.
Okay.
But beyond that, things change. Cardiac output tends to drop off first, pretty significantly. Then, as the loss gets larger, arterial pressure starts to fall more dramatically. The source indicates that if you lose, say, 40 to 45% of your total blood volume rapidly, both CO and pressure essentially drop to zero, and that's obviously incompatible with life.
40 to 45%. That's a massive loss. But the body fights back hard, right, with those sympathetic reflexes.
Oh, absolutely. These reflexes are crucial. They get triggered primarily by the drop in arterial pressure, which is sensed by baroreceptors in the arteries, also by low-pressure sensors in the big veins and the chest area. This all signals the brain to unleash a powerful sympathetic nervous system response.
And what does this sympathetic surge actually do to help? What are the key effects in hemorrhagic shock?
The text lays out three really important effects. First, widespread vasoconstriction. The arterioles, the small arteries feeding the tissues, constrict in most parts of the body. This increases what's called total peripheral resistance, or TPR.
Increasing TPR, what's the main benefit of that?
It primarily helps to prop up the falling arterial pressure. It doesn't necessarily improve flow through those constricted areas, but it maintains the overall pressure head.
Okay, pressure support. What else?
Second, the veins and the body's venous reservoirs also constrict strongly. This is vital because it squeezes the remaining blood volume back towards the heart, helping to maintain venous return despite the overall lower volume.
Pushing the available blood back to the pump.
Exactly. And third, heart activity ramps up significantly. Both the heart rate and the force of contraction increase. The heart rate can jump from, say, a normal 72 beats per minute way up to 160, even 180, as the body tries desperately to compensate for pumping less volume with each beat.
Squeeze harder, pump faster. How much difference do these reflexes actually make? The source gives a number, right?
It makes a huge difference. The source estimates that without these reflexes, losing just 15 to 20% of blood volume could be fatal. But with these reflexes working, a person might tolerate losing 30 to 40%. They essentially double the amount of acute blood loss the body can withstand before things collapse.
That's a remarkable buffer. The text also notes these reflexes are generally better at keeping the pressure up than keeping the cardiac output up. Why is that?
Well, because a major component is that arterial or constriction-raising PPR. That directly boosts pressure. But it's really the venous constriction that's more helpful for maintaining venous return and less cardiac output. So while both help pressure, the venous part is more key for CO. The system seems heavily weighted towards preventing a catastrophic pressure drop. That's likely why, in that figure concept, pressure might hold up better initially than CO.
And there's that mention of a specific point, around 50 millimeter Hg arterial pressure, where something even more drastic happens.
Yes, that's the CNS ischemic response, CNS meaning central nervous system. When arterial pressure falls so low, below about 50 millimeter Hg, blood flow to the brain itself becomes critically reduced. The brain's own control center for blood pressure, the vasomotor center, senses this lack of oxygen ischemia and triggers an absolutely massive, last-ditch, all-out sympathetic discharge throughout the body.
A final desperate measure by the brain.
Pretty much, trying to pull everything back from the brink.
Do these powerful reflexes offer any special protection for the brain and the heart themselves?
Yes, and this is really important. The source points out that the sympathetic stimulation doesn't actually cause significant constriction of the blood vessels within the heart muscle, the coronary arteries, or within the brain, the cerebral arteries.
Oh, interesting.
Plus, both the heart and the brain have excellent local autoregulation.
Autoregulation, what does that mean here?
It means those vascular beds can adjust their own resistance to maintain relatively constant blood flow, even if the incoming arterial pressure fluctuates, at least within a certain range. The source says blood flow to the heart and brain stays pretty much normal as long as the mean arterial pressure is above about 70 millimeters Hg.
So while the rest of the body might be getting squeezed, blood flow-wise.
Exactly. Flow to less immediately critical areas like skin, muscle, kidneys, gut might be cut down drastically by vasoconstriction, but the body fiercely protects flow to the brain and heart. It prioritizes the command center and the pump.
A crucial survival strategy. Yeah. Okay, let's return to that split between non-progressive and progressive shock, using hemorrhage as the example. That figure TUM 4-2 concept you mentioned, showing a critical threshold of blood loss.
Right. That concept really illustrates the point. Below a certain amount of blood loss, the body's protective negative feedback mechanisms, those reflexes and other responses we'll get to, are strong enough to win. They eventually restore CO and pressure back to normal. That's non-progressive compensated shock. Recovery happens.
But if you lose just a tiny bit more blood, crossing that threshold.
That seemingly small difference, the source indicates, can be absolutely critical. Cross that threshold, and the deteriorative forces, the positive feedback loops, start to overpower the compensatory negative feedback. The shock becomes progressive, and without intervention, it spirals towards death.
Okay, so in non-progressive shock, the key is the strength of those negative feedback systems.
Yep.
Factors that cause recovery, as the source puts it. We talked about the sympathetic reflexes. What other recovery mechanisms does the source list?
Okay, besides the rapid sympathetic stuff, the baroreceptor reflex, and the CNS ischemic response, there's something called reverse stress relaxation. This is a bit slower, developing over maybe 10 minutes to an hour. The blood vessels, especially the veins, sort of gradually tighten up around the smaller blood volume that's left.
Shrinking the container to better fit the reduced amount of fluid.
That's a good way to think about it. It helps the remaining volume fill the system more effectively, supporting venous return. Then, there are several really important hormonal responses that kick in over minutes to hours.
Hormones join the fight.
Absolutely. The kidneys sense the low pressure and release renin. Renin starts a cascade that produces angiotensin II. Angiotensin II is a very powerful vasoconstrictor, squeezing arterioles, and it also tells the kidneys to hang on to salt and water, reducing urine output.
Okay, constricting vessels and conserving fluid.
Then the pituitary gland in the brain releases more vasopressin, which you might know as ADH, antidiuretic hormone. ADH is also a vasoconstrictor, hitting arterioles and veins, and it has a major effect on the kidneys, making them reabsorb much more water.
Another fluid saver and vessel constrictor.
Yep. And don't forget the adrenal glands sitting on top of the kidneys. They pump out more epinephrine and norepinephrine into the bloodstream, reinforcing all those sympathetic effects, vasoconstriction, increased heart rate, and strength.
So a whole cocktail of hormones backing up the nerve signals. What about actually getting the lost volume back over the longer term?
Right, the body works on that too. Over hours to days, fluid gets pulled from the gut and from the interstitial spaces, the fluids surrounding the cells back into the bloodstream to help replenish volume. The kidneys, under the influence of ADH and angiotensin-aldosterone, conserve salt and water very efficiently. And if the person is conscious, intense thirst and even a craving for salt will drive them to replenish fluids and electrolytes.
It's quite a layered response then. Fast nerves, slower hormones and vessel adjustments, and then even slower fluid shifts in conservation.
Exactly. It's this whole orchestra of negative feedback mechanisms working together to pull the system back from the brink. And in non-progressive shock, they succeed.
But if the shock is too severe, if it crosses that critical threshold, then the progressive stage kicks in, driven by those positive feedback loops, the vicious cycles that actually worsen cardiac output. Like that figure 24:3 concept. Let's break down these mechanisms, the ones that make shock spiral downwards.
Okay, the first big one, and the source calls it perhaps the most important factor in the late lethal stages, is cardiac depression. As arterial pressure falls, blood flow through the coronary arteries supplying the heart muscle itself drops. The heart muscle becomes ischemic, starved for oxygen.
So the pump starts failing because it's not getting enough fuel.
Exactly. A weaker heart pumps less blood, which lowers arterial pressure even more, which further reduces coronary blood flow, which weakens the heart further. You see the positive feedback loop.
Yeah, that's a classic downward spiral.
The source references a figure 24:4 type concept showing this over time. Initially, the heart might hold up okay due to its reserve capacity, but after hours of low coronary pressure, its function just plummets. This cardiac deterioration is often the ultimate reason progressive shock becomes fatal.
Devastating. The heart essentially gives out under the strain. What's another major positive feedback loop?
Vasomotor failure. Remember how the sympathetic system ramps up early on? Well, if the brain's vasomotor center, the control hub, doesn't get enough blood flow for too long, say 10 or 15 minutes of severe ischemia, the neurons in that center start to fail. They become depressed, less active, eventually inactive.
So the command center shuts down.
Right. This leads to a progressive loss of sympathetic tone. Instead of constricting, blood vessels start to dilate inappropriately. This drops venous return, drops cardiac output, and accelerates the shock progression. Again, the shock damages the very system trying to compensate.
Crikey. What else contributes to this downward spiral?
Blockage by sludged blood. As blood flow slows way down in the tiny vessels, the microcirculation, the local tissues become acidic. You get lactic acid buildup from lack of oxygen, carbonic acid from CO2 buildup. This acidity, plus other factors from damaged tissues, causes red blood cells to clump together to agglutinate.
Like tiny log jams in the smallest vessels.
Exactly. This sludged blood makes it much harder for blood to flow, increases resistance, and further compromises tissue perfusion, making the shock worse.
And do the vessels themselves start to fail?
Yes, that's increased capillary permeability. After hours of oxygen deprivation and lack of nutrients, the walls of the capillaries themselves get damaged and become leaky. They start letting plasma fluid and even proteins seep out of the bloodstream into the surrounding tissues.
So volume is lost from the circulation even without external bleeding.
Correct. This loss of circulating volume further reduces venous return, lowers CO, and worsens the shock. The source notes this tends to happen more in the later stages.
Seems like everything starts breaking down. What about toxins?
That's another factor, release of toxins by ischemic tissue. As tissues are damaged by lack of blood flow, they release various substances, histamine, serotonin, various destructive tissue enzymes. The source specifically highlights endotoxin.
Endotoxin, that comes from bacteria, right? Especially in the gut.
Yes, exactly. From the cell walls of gram-negative bacteria, which are abundant in our intestines. Normally, the gut barrier keeps most of it contained, but in shock, blood flow to the gut is often severely reduced due to vasoconstriction. This damages the intestinal wall, making it leaky, allowing bacteria and endotoxin to get into the bloodstream in larger amounts.
And what does endotoxin do once it's in the circulation?
It's bad news. It can directly depress the heart muscle's function. It can also cause cells around the body to actually increase their metabolism, burning more oxygen, even when the supply is already critically low. It really exacerbates the mismatch. The source notes it plays a particularly big role in septic shock, but it can contribute in other severe shock states too.
Wow, so internal toxins adding fuel to the fire. The source also talks about just generalized cellular deterioration.
This is really the endpoint for cells all over the body suffering from prolonged lack of perfusion. Key cellular machinery starts to fail. The ion pumps in the cell membranes can't keep up, so sodium and chloride leak in, potassium leaks out, and the cells swell up.
Cells literally getting waterlogged and losing essential electrolytes.
Yes. The mitochondria, the powerhouses of the cell, become depressed. They can't produce energy efficiently. Lysosomes, which contain powerful digestive enzymes, can rupture inside the cell, releasing those enzymes to basically self-destruct the cell.
Autolysis, self-digestion.
Right. Overall cellular metabolism, like using glucose for energy, becomes severely depressed. Hormones like insulin become much less effective. It's a fundamental breakdown at the cellular level.
And this leads to obvious organ damage.
Definitely. The source mentions specific examples. The liver, vital for metabolism and detox, can suffer necrosis, cell death, especially in vulnerable zones, like in that figure 24-5 concept. The lungs can develop severe edema and oxygenation problems, shock lung. And the heart, as we discussed, develops depressed contractility and patchy damage.
The source also mentions patchy areas of tissue necrosis more broadly.
Yeah, because the reduction in blood flow isn't perfectly uniform. Some tiny areas within tissues inevitably get less flow than others. Combined with the overall low flow, this leads to small pockets of cell death or necrosis. This is seen around the venous ends of capillaries, where oxygen is lowest, in those specific liver zones, in kidney tubules, contributing to organ failure that might show up days later, even if the person survives the initial shock episode.
And finally, a really pervasive problem worsening everything. Acidosis in shock.
Absolutely critical. With poor oxygen delivery, cells switch to anaerobic metabolism, which produces a lot of lactic acid. At the same time, poor blood flow means CO2 isn't removed effectively, leading to carbonic acid buildup. This combination creates widespread tissue acidosis, both locally and systemically.
And why is acidosis so bad in this context?
Increased acidity further depresses the function of virtually all cells, including heart muscle cells and the smooth muscle in blood vessel walls. It dampens enzyme activity. It contributes significantly to those positive feedback loops, pushing the shock further along its downward spiral.
Okay, so let's recap these deteriorative positive feedbacks. Cardiac depression, vasomotor center failure, sludge blood blocking microvessels, leaky capillaries losing volume, toxins like endotoxin being released, widespread cellular breakdown, patchy tissue death, and pervasive acidosis. They all feed into each other.
That's the grim picture. Each one worsens the circulatory state, which in turn makes each of these processes worse. The source emphasizes again, positive feedback doesn't always win. The body has powerful negative feedback defenses. But when shock is severe enough, the intensity of these positive feedback loops overwhelms the defenses. That's when you cross the critical threshold into progressive and potentially irreversible shock.
Which brings us squarely to that final stage, irreversible shock.
This is the point of no return. Even if you apply all the right therapies, the underlying damage is too profound and the circulation will inevitably fail again, leading to death. The source describes this almost paradoxical situation referenced in a figure 24-6 type concept.
What is the paradox?
Sometimes, giving treatment like a blood transfusion might actually bring the cardiac output and arterial pressure back up to near normal levels temporarily. Things might look better for a short while.
But it doesn't last.
Exactly. The improvement is fleeting. The circulation rapidly deteriorates again, and if you try another transfusion, it's even less effective. The underlying machinery is just too broken.
And why? What makes it irreversible at that point? The source lists reasons.
It's the culmination of all that damage we discussed. Widespread tissue injury, the release of all those destructive cellular enzymes, severe intractable acidosis, deep-seated damage to the heart muscle that might not be immediately obvious. Just numerous destructive factors have taken hold and caused fundamental disruption.
Is there one particular cellular problem the source highlights as being especially critical for irreversibility?
Yes, this is a really key insight into the ultimate cellular cost. The source emphasizes the profound depletion of cellular high-energy phosphate reserves. We're talking about ATP, adenosine triphosphate, the cell's immediate energy currency, and its backup, creatine phosphate.
The cell's batteries run completely flat.
Essentially, yes. And it's worse than just running flat. As ATP gets used up and broken down through ADP and AMP, you end up with adenosine. The problem, the source explains, is that a lot of this adenosine leaks out of the damaged cells into the blood.
Okay, and why is that so bad?
Because once it's in the blood, it gets converted into uric acid. And uric acid can't easily get back into the cells, nor can it be used to rebuild those essential ATP stores. The cell has basically lost the building blocks for its energy currency.
And making new adenosine from scratch
Is incredibly slow. The source estimates the cell can only synthesize maybe 2% of its normal amount per hour. So replenishing those energy stores after they've been depleted and the precursors have leaked out is extremely difficult, maybe impossible in the time frame needed for survival.
Wow, so the fundamental energy capacity of the cells is just gone, lost.
That's what the source suggests. This depletion of high-energy phosphates is described as one of the most devastating consequences of severe, prolonged shock, and a major reason why it becomes irreversible. Even if you restore blood flow, the cells lack the basic energy to recover and function. The engine is fundamentally broken at the molecular level.
That cellular detail really provides that deep understanding of why recovery eventually becomes impossible. We've focused a lot on hemorrhage, but the source also covers hypovolemic shock from other causes.
Right. Low volume doesn't just mean losing whole blood. You lose the fluid part, the plasma, and that can cause plasma loss, hypovolemic shock.
What kind of situations lead to significant plasma loss?
The source gives examples like intestinal obstruction. If the bowel gets blocked, venous pressure in the gut wall can rise, forcing plasma fluid and protein to leak out into the bowel wall or lumen. Another major cause is severe burns, or any condition where large areas of skin are lost, plasma just oozes out from the damaged surfaces.
And is there a specific complication with just losing plasma compared to whole blood?
Yes, because you're losing fluid but keeping the red blood cells, the remaining blood becomes more concentrated, more viscous, thicker. The source notes this increased viscosity can aptly sludge up the microcirculation even more, making blood flow harder and worsening tissue perfusion.
Okay, what about losing fluid from the entire body, not just plasma?
That's dehydration. This involves loss of fluid from all compartments inside cells, between cells, and in the blood plasma. Severe dehydration reduces blood volume enough to cause hypovolemic shock, similar in effect to hemorrhage.
What causes that kind of severe dehydration?
Things like excessive sweating, without fluid replacement, severe diarrhea or vomiting, conditions where the kidneys lose too much fluid like uncontrolled diabetes, or simply not taking in enough fluids and electrolytes. Also, destruction of the adrenal cortices is mentioned.
The adrenal glands again. How does destroying them cause dehydration?
Because the adrenal cortex makes aldosterone, a hormone crucial for telling the kidneys to reabsorb sodium, and water follows sodium. Without aldosterone, the kidneys waste massive amounts of salt and water into the urine, leading to severe dehydration and potential shock.
Understood. Trauma is also listed as a common shock cause.
Yeah, often trauma causes shock simply because of bleeding, internal or external. But the source makes a point that severe trauma, like major crush injuries, can cause shock even without massive hemorrhage. The extensive tissue damage itself can damage capillaries locally, causing large amounts of plasma to leak out into the injured tissues, leading to hypovolemia that way.
So internal fluid loss into the damaged area.
Exactly. The source suggests that while some have proposed toxic factors, traumatic shock seems to be primarily hypovolemic in nature, perhaps with a very minor neurogenic component from pain sometimes.
Okay, that leads us nicely to neurogenic shock, which the source explicitly says happens without any loss of blood volume.
Correct. In neurogenic shock, the problem isn't the volume, it's the container. There's a sudden, widespread loss of vasomotor tone. That's the background nerve signal that keeps blood vessels, especially veins, partially constricted.
So the whole system just relaxes and expands.
Pretty much, especially the veins. They dilate massively. So now, even though the blood volume is normal, it's not enough to fill the suddenly much larger vascular space adequately. Blood tends to pool in these dilated veins instead of returning to the heart.
Venous pooling.
Right. This dramatically reduces mean systemic filling pressure, reduces venous return, and therefore drops cardiac output, causing shock.
What could cause such a sudden loss of vascular tone?
Several things mentioned in the source. Deep general anesthesia can depress the brain's vasomotor center. Spinal anesthesia, if it blocks the sympathetic nerve outflow high enough up the spine, can do it. Certain types of brain damage, like concussion or injury to the base of the brain, can paralyze the vasomotor center. And interestingly, while brief brain ischemia causes that massive increase in sympathetic tone, the CNS ischemic response, prolonged brain ischemia, more than 5–10 minutes, can actually completely knock out the vasomotor center, leading to severe neurogenic shock.
Wow, so the brain's control system can go from overdrive to complete failure if ischemia persists. What about anaphylactic shock?
Anaphylaxis is a severe, potentially fatal allergic reaction. It happens when the body has a massive immune response to something it's sensitized to. It could be an insect sting, a food, a drug. This antigen-antibody reaction triggers specialized cells, mast cells, and basophils to release huge amounts of histamine and similar potent substances.
And what does all that histamine do to cause shock?
It hits the circulation hard in several ways. It causes widespread vasodilation, especially of veins, leading to that venous pooling and reduced venous return. It also dilates arterioles, causing a sharp drop in arterial pressure. And critically, it makes capillaries all over the body incredibly leaky, allowing rapid loss of fluid and protein out of the blood and into the tissues.
So you get pooling, pressure drop, and fluid leaking out all at once from the allergic reaction.
Yes, the combination leads to a profound reduction in venous return and circulatory collapse. It can happen very, very quickly. The source notes that injecting a large dose of histamine directly causes a similar state, called histamine shock.
Okay, the last major type covered is septic shock. The source flags this as extremely important clinically, the most frequent cause of shock death in hospitals after cardiogenic shock.
Yeah, its prevalence is a major concern. Septic shock is caused by a severe, widespread bacterial infection that's often spread through the bloodstream. Many types of bacteria can cause it, both gram-positive and significantly gram-negative bacteria that release endotoxin.
What kind of infections typically lead to sepsis and potentially septic shock?
Examples given include peritonitis infection within the abdominal cavity, maybe from a ruptured appendix or bowel surgery gone wrong, widespread skin infections like cellulitis or gangrene spreading into the blood, or infections starting in the kidneys or urinary tract that become systemic.
Does septic shock look different from other types, clinically? Does it have unique features?
Often, yes. Especially early on, high fever is very common. There's usually significant vasodilation, especially in the infected tissues, but often generalized. And here's a key point. The source says about half of patients with septic shock actually have a high cardiac output, at least initially.
High CO. That seems totally backward for shock. How is that possible?
It's still shock because despite the high volume being pumped, tissue perfusion is still inadequate relative to the massively increased metabolic demands caused by the infection, the fever, and the toxins. Or the blood flow patterns are disrupted, shunting past tissues. That high CO is driven by the widespread vasodilation, lowering resistance, and the high metabolic rate.
Ah, okay. So the high output is a sign of the system trying to compensate for leaky, wide-open vessels and sky-high tissue needs, but it's still failing to deliver effectively.
Got it. What else is characteristic?
Blood sludging, like we discussed before, is common due to red cell agglutination. And a really dangerous complication frequently seen is DIC, disseminated intravascular coagulation.
DIC, what's that?
It's a pathological process where tiny blood clots start forming throughout the microcirculation all over the body, but especially in organs like the gut. This widespread clotting uses up all the body's available clotting factors and platelets. So paradoxically, while you have microclots blocking vessels, you also develop a severe bleeding tendency because there's nothing left to form normal clots where needed. Patients can hemorrhage, particularly from the gut wall.
Clotting and bleeding at the same time, that sounds incredibly difficult to manage. It's a major challenge. The source points out that the very first signs of sepsis might just be fever and signs of infection, not obvious circulatory collapse. The shock develops later as the infection and toxins cause plasma leakage, vasodilation, and eventually the progression resembles the late stages of hemorrhagic shock, driven by those same familiar vicious cycles.
Understanding all these different paths to shock and the common destructive pathways they converge on really emphasizes the need for effective treatment. How does the source frame the physiology of treatment? What are the main strategies?
Logically, treatment focuses on fixing the underlying cause if possible, and crucially supporting the circulation to break those positive feedback loops. The most fundamental approach discussed is replacement therapy.
Replacing whatever was lost.
Exactly. If it's hemorrhagic shock, the ideal is whole blood transfusion to restore both volume and oxygen carrying capacity. If it's primarily plasma loss, like from burns, then administering plasma is key to restore volume and the colloid osmotic pressure needed to hold fluid in the vessels. If it's dehydration, then the right electrolyte solution is needed.
What if you don't have blood or plasma immediately? Are there substitutes?
Yes, the source mentions plasma substitutes. The critical thing they need to do is provide colloid osmotic pressure like the plasma proteins do to keep fluid inside the blood vessels. Dextrin is given as an example. It's a large polysaccharide molecule that stays in the circulation for a while. It helps pull fluid back into the vessels and expand volume, though the source notes you still need to provide electrolytes alongside it.
Okay, volume is key. What about drugs? Sympathomimetic drugs are discussed.
Right, these are drugs that mimic sympathetic nerve stimulation. Think norepinephrine, epinephrine, drugs like that. They have specific value in certain types of shock.
Which ones are they most useful for?
They are particularly beneficial in neurogenic shock, where the core problem is a lack of sympathetic tone causing vasodilation. These drugs essentially replace that missing tone. They are also very important in anaphylactic shock, where histamine causes massive vasodilation and leakiness. The vasoconstrictor effects of sympathomimetics directly counteract histamine's effects.
Makes sense. Are they helpful in hemorrhagic shock from bleeding?
The source says generally not very valuable. Why? Because in severe hemorrhagic shock, the body's own sympathetic system is already firing on all cylinders, maximally activated. Adding more drugs that do the same thing doesn't provide much, if any, additional benefit because the system is already saturated.
Right, can't boost a system that's already at its absolute maximum via the same mechanism. Okay, what other therapies are mentioned?
A very simple but potentially very helpful one. The head-down position, tilting the patient so their head is lower than their feet, maybe by a foot or so.
How does that help?
Gravity. It helps blood from the lower body drain back towards the heart, improving venous return and boosting cardiac output. The source calls it an essential first measure, especially for hemorrhagic and neurogenic shock.
Simple but effective. What about giving oxygen?
Oxygen therapy. It seems logical, right? Shock involves lack of oxygen to tissues. Giving extra oxygen can be beneficial sometimes. However, the source points out its usefulness is often limited.
Why limited?
Because the main problem in most shock states isn't getting oxygen into the blood in the lungs, unless there's also lung failure. The problem is the failing circulation's inability to transport that oxygenated blood to the tissues. If the delivery truck network is broken down, having more cargo at the depot doesn't fix the delivery issue.
Good analogy. Transport is the bottleneck. Lastly, glucocorticoids. Steroids.
Yes, adrenal cortex hormones like cortisol or synthetic versions. They're often used in severe shock. The source gives a few reasons, some based on empirical evidence rather than fully understood mechanisms. They might help increase the strength of the heart, especially in late shock. They might help stabilize lysosomes within cells, preventing release of those destructive enzymes, and they possibly aid glucose metabolism in damaged cells.
So potentially helping the heart, protecting cells, maybe boosting energy use, a multifaceted approach for severe situations.
Seems to be the rationale.
Okay, the source wraps up by touching on a related ultimate crisis, circulatory arrest.
Right, this is the complete stopping of all blood flow, usually due to either cardiac arrest, the heart just stops beating, or ventricular fibrillation, where the heart muscle quivers chaotically and doesn't pump any blood.
Can anything be done?
Ventricular fibrillation can sometimes be stopped by a strong electric shock defibrillation, allowing a normal rhythm to potentially restart. For cardiac arrest, immediate CPR, cardiopulmonary resuscitation, plus getting oxygen into the lungs is crucial to maintain some minimal flow, especially to the brain, hopefully buying time until a heartbeat can be restored.
And the huge concern with arrest is always the brain.
Right, absolutely. The brain is incredibly vulnerable to lack of blood flow. The source states that after just 5 to 8 minutes of total arrest, there's a high risk of permanent brain damage, and after 10 to 15 minutes, it's almost certain. That window is terrifyingly short.
Traditionally, we thought of that brain damage as purely from lack of oxygen hypoxia.
Hmm.
Has that view changed?
Somewhat, yes. The source mentions newer research suggesting that while hypoxia is definitely central, another major factor contributing to the rapid brain deterioration might be the formation of tiny blood clots, microthrombi, within the brain's blood vessels during that period of zero or near zero flow.
Clocks forming in the brain's circulation during the arrest.
Exactly. Experiments mentioned involved either replacing blood with fluid to prevent clotting or using powerful clot-busting drugs or anticoagulants. In those animal studies, the brain was able to tolerate significantly longer periods of arrest, maybe up to 30 minutes, without the same degree of severe damage seen typically after just 5–10 minutes.
So, preventing those microclots might be as important as restoring flow and oxygen.
That's the implication. It suggests the damage isn't just oxygen starvation, but also involves these microvascular blockages developing very quickly, adding another layer to the challenge of protecting the brain during cardiac arrest.
Fascinating. Well, we have certainly taken a deep dive today into circulatory shock.
Mhm.
We've gone from the basic definition that inadequate tissue perfusion through all the diverse causes, whether it's pump failure, volume loss, or the vessels themselves misbehaving.
And we've really traced that critical balance between the body's own powerful compensatory mechanisms, the negative feedback loops trying to restore order, and those dangerous positive feedback loops, the vicious cycles that drive the progression towards potentially irreversible damage.
Seeing how different types of shock, while starting differently, often converge on similar pathways of deterioration, cardiac depression, acidosis, cellular damage, that really reinforces the underlying physiological principles.
And exploring the treatments, you see how they're targeted at interrupting those cycles and supporting the failing system.
Absolutely. Going through this material from the source piece by piece really gives you that layered, nuanced understanding. You start to see the interconnectedness, how failure in one part cascades through the system. It's the kind of foundational knowledge professionals in the field build upon. It truly is. And reflecting on everything we've covered, especially those devastating end-stage problems like the depletion of cellular energy, the loss of ATP precursors, those microclots forming, it brings up a final thought for you, the listener. Considering how fundamental and difficult to reverse that damage becomes, what does this deep dive truly teach us about the absolute critical importance of early recognition and intervention? How crucial is it to act decisively before shock reaches that stage where cellular resilience is fundamentally compromised and recovery becomes impossible? It really highlights that understanding these mechanisms isn't just academic, it's potentially life-saving.
A very powerful point. That understanding underscores why time is so absolutely critical in managing shock.